All right, let's move on to the first lecture. Our first presentation is the J.M. Gorell, MD lecture. Dr. Gorell was a highly dedicated movement disorder specialist who practiced for many years at Henry Ford Hospital. He was involved in patient care, education, conducted research, and he had an emphasis on epidemiological studies. He had been active with the Michigan Parkinson Foundation since its inception, being on the board of directors as chairman, and also on the professional advisory board. And so we honor his name and his efforts by naming a lecture in his memory. And so it's an honor and privilege to introduce my good friend, Dr. Hubert Fernandez, who's been selected to present this lecture. He's currently professor of medicine and neurology at the Cleveland Clinic Lerner College of Medicine, Case Western Reserve University, and the head of Movement Disorders Center for Neurological Restoration at the Cleveland Clinic in Cleveland, Ohio. And if I read the rest of his biography, he wouldn't have any time to present, so I'm just going to give you some highlights here. He's an internationally recognized expert in movement disorders who's been voted one of the best doctors in America by his peers. He's a very active and productive researcher and has initiated or participated in over 50 clinical trials and has published his findings in well over 300 articles and abstracts on Parkinson's disease, cervical dystonia, blepharospasm, and other movement disorders. And he has nearly 40 published book chapters and books to his credit. And he will be speaking on recent advances in understanding and treating Parkinson's disease. Let's give Dr. Fernandez a big welcome.
Thank you. Thank you very much. Let me just think I should do this. It's always speaker. Where is the? I have a Mac, so I forgot this one. Okay. So thank you so much for having me. It's great to see old friends and colleagues. I don't really feel like someone from the outside. I was telling my driver last night that I've been to that Detroit airport a million times, but that was the first time that I actually got out of that airport. I always connect somehow. And it's actually quite nice. So thank you so much, and thank you, Kelvin, for the very nice introduction. Hopefully I could, hopefully I don't disappoint too much. So the topic that was given to me was really recent advances in our understanding and treating Parkinson's as well. But when I looked at the program, there's several lectures on treatment. Dr. Lewitt, Dr. Schwab will be talking about medical and surgical treatment, so I kind of avoided that. And then there is also a lot of talk on cognition, and so I avoided that as well, and mood. And of course, I didn't want to touch falls and gait freezing. Not that I know much about it, but the little that I know, I just took it out. So I'm left still with a lot. It's our understanding, basically, just our basic understanding of Parkinson's disease and how the recent discoveries that have been published, in the last decade or so, especially in the last 2-3 years, have really changed the way we view this illness. So I'm going to concentrate on those and hopefully leave a lot more for the rest of the speakers this afternoon. So let me just see how this works. Okay. So these are my disclosures. I am a clinical trialist, and so I get a lot of grants from different companies and industry, the federal government, and foundations as well, and hopefully, but I have no owner interest in any of these companies. So hopefully by studying all of them equally, they neutralize each other, and I try to be as balanced as I can. Fortunately for this talk, I'm not going to talk about treatment a whole lot, and so there isn't much to be biased on. So let me just start by, acknowledging that this all started, when James Parkinson described the disorder nearly 200 years ago. So next year will be the 200th year when our hero, James Parkinson, first described this mysterious, challenging, fascinating illness that's aptly named after him. To this date, we don't have a cure yet for this illness, but we know a lot more. We know that dopamine loss is a key pathology in Parkinson's disease, but we also know that it's not the only thing, that there are many other neurotransmitters and involved in this Parkinson disorder. When I was in medical school, Parkinson's disease was a neurological disorder. Now it still is, but it's more than that. We now recognize that Parkinson's disease is a heterogeneous, progressive, multi-system, multi-organ, neurological, medical, surgical, behavioral, psychiatric, and even dermatological disorder. And while we don't have a cure, we have now several medications, and we continue to improve on this almost on a weekly basis or on a monthly basis, with more and more treatments available, at least symptomatic treatments, and the way we use our medications right now, and surgical treatments as well. So a lot has happened since 1817, but a lot more. We have still quite a bit of journey ahead of us. So let me start by discussing some highlights of Parkinson's disease that really is making our thinking of this disorder evolve somewhat. So for the Gorell lecture, I can't think of at least starting with epidemiology and just spending a few slides on it. So Parkinson's disease, although not exclusively a disease of the elderly, is really quite common in the senior population. Now over 10 million people worldwide, about 1.5 million in North America, have Parkinson's disease. About 50 to 60,000 patients are diagnosed every year in our continent alone. In fact, our population is aging, and as our general population ages, if we do not find a cure for Parkinson's disease in the next 20 years, there will be more people dying with Parkinson's disease and likely with Parkinson complications than people dying with GI cancer, lung cancer, and breast cancer combined. So I view this as an epidemic, and I view this as a disease that we need to really study really urgently. Otherwise, the landscape of our healthcare will really be different in just 2 decades from now. So one of the more intriguing epidemiological data and quite consistent epidemiological data that we have is this, that the disorder affects men almost twice as much as women. 1.5 to 2 is to 1. We don't know why that is. It might be because of a possible neuroprotective effect of estrogen activity in women more than men, but we could just kind of speculate. The other intriguing epidemiological study that is rather consistent is that there is a lower incidence of Parkinson's disease amongst Asians and Africans as compared to Europeans and North Americans. This is obviously a little bit more difficult to ascertain compared to the gender one because of demographic differences and methodological limitations, but nonetheless, it's quite intriguing. Now, for the etiology, like the source of Parkinson's is still mysterious for us. But in a subset of patients, the genetic source is quite clear. The spectrum of the genetic role in Parkinson's disease is quite broad. And you have the much less common, about less than 10% incidence of Parkinson's disease comes from direct, highly penetrant Mendelian genetics. These are your autosomal dominant or your autosomal recessive genetic mutations in Parkinson's disease. But much more common would be the more multifactorial genetic susceptibility variants in Parkinson's disease that are really modified by environmental triggers. So our understanding, especially of the Mendelian genetic role in Parkinson's disease, really the role, the limited but significant role of genetics in Parkinson's disease was quite cemented by this really creative, simple but elegant study on Parkinson twins led by Carly Tanner in California. So this is the PD twin study that I think Kelvin and I were very fortunate to participate in. We actually flew all over the country and we studied twins with Parkinson's. The cohort we used here are the twins from World War II. They've obviously now they're aging, and so they're at that time in their lives where they're developing Parkinson's if they were going to develop Parkinson's disease. And we followed all the twins in the World War II registry, both identical twins and fraternal twins. And we saw if one twin had Parkinson's, would the other twin have Parkinson's as well? The idea being that if there were more identical twins with Parkinson's compared to fraternal twins, then the genetic source of Parkinson's disease was quite significant. Now, if the incidence of identical twins with Parkinson's was the same as that of fraternal twins, then genetics is probably not so highly relevant. So what we saw was, there was actually not much of a difference in incidence of Parkinson's in twins in fraternal or identical twins, except in those who develop Parkinson's disease before the age of 50. For patients who develop, for twins, identical twins who have who were diagnosed with Parkinson's disease before the age of 50, their other identical twin was 6 times more likely to have Parkinson's disease compared to a fraternal twin counterpart. So the bottom line for this study is that yes, there is a clear genetic role of Parkinson's disease, especially amongst those who present before the age of 50 years old. So after that, through the years since the discovery of the first genetic mutation in Parkinson's disease in 1997, way back then, in a large Italian family, the alpha-synuclein gene, there have been an explosion of all these genetic mutations, and we now have over 20 genetic susceptibility variant genes loci seen, and I suspect that this list is going to get even bigger as years go by. I know it's a handful, it's a lot to remember. I don't have this memorized. I cheat, I have my cheat sheet when this happens. Let me simplify a few things. I just want you to remember a few relevant genetic disorders. So in the Mendelian traits, you have your autosomal dominant genetic Parkinson's disease when you only need one parent to carry the gene mutation, and each sibling of that parent with a gene mutation has a 50% chance of developing of acquiring the gene mutation. And then you have the autosomal recessive where you need 2 parents carrying both parents carrying the gene mutation. And each of their siblings will have a 25% chance of getting that mutation. So those are the two, your classic Mendelian inheritance. So of the autosomal dominant, there are two genes that you really ought to remember. These are the two ones that acquire the most attention and the most research and really have changed the way we view Parkinson's. And one is the SYNCA or alpha-synuclein, that's the easier way, alpha-synuclein gene mutation. And the other one is the LRRK2 or the LRRK2 gene mutation. So these two I'm going to explain in a bit more detail. And then of the autosomal recessive, you have the Parkin gene, the PINK1 gene, and the DJ1 gene mutation. So these ones have a more homogeneous, a more uniform appearance of Parkinson's disease. They're quite earlier onset. They have a slower disease progression, thankfully, and they respond very well to levodopa. Your clue here is a family history. It may skip generations because it's autosomal recessive. Younger, much younger onset than usual, then you could suspect one of these three genes. And then examples of kind of highlights or of the more heterogeneous kind of presentation would be the PARK9, PARK14, PARK15 gene mutations. So these are a bit more heterogeneous compared to the Parkin, PINK1, and DJ1. They have other features sometimes that are not commonly seen in Parkinson's disease, like hyperreflexia, spasticity, dystonia, dementia. When you see something like that, a little bit of family history, some odd features, increased reflexes, spasticity, dementia, dystonia, and then you might want to suspect Part 9, 14, and 15. So that's kind of how I see it, and the others are all mush to me, and I need my cheat sheet before I could reasonably even diagnose them with that. So the gene that started it all is this alpha-synuclein gene. Way back in 1997, it was a change in the base pair mutation of the alpha-synuclein in a large Italian family with early onset Parkinson's disease. And over the years, so that's what we call a point mutation. That was the first one that was diagnosed. And then over the years, we've discovered that it's not just point mutations, but there are what we call multiplication mutations. So these are duplications or triplications of the alpha-synuclein gene. And the higher the number of copies, it was correlated to the severity of the disease. And then much more recently, the alpha-synuclein gene is now no longer just a pure Mendelian inheritance. We have also now discovered that there are common promoter gene variant, susceptibility variant genes associated with the risk of developing Parkinson's. So there are now also gene susceptibility variants for the risk of having Parkinson's and not necessarily a Parkinson mutation itself. So despite all the attention they got, the mutation in general, the Mendelian mutation, is quite rare. It occurs in less than 0.1% of patients, and therefore it's something you ought to know, but it's probably not something you'll meet on a day-to-day basis. So we don't really check for genetic testing for even most of our familial Parkinson's disease because it's very rare. And so, but it's important because alpha-synuclein is a major component of Lewy bodies, and Lewy bodies is the pathological hallmark of Parkinson's disease. And so alpha-synuclein gene mutation animal models really have revolutionized the way we think about Parkinson's disease. More importantly, we are now able to identify, collect, and measure alpha-synuclein in blood, in spinal fluids, and that is being investigated now as a potential biomarker, perhaps one of our first biomarkers in Parkinson's disease in the next few years. So this is a relevant discovery. As rare as it involves people, it has really given us a window of our understanding of Parkinson's disease. The one that's more relevant would be the LRRK2 mutation. It's also autosomal dominant, so every parent can have a 50% chance of passing on this mutation to their child. It is 2% of all Parkinson's disease. Any Parkinson's patients we have with or without a family history, 2% of them, 2 out of 100, will have the LRRK2 gene mutation. If there is an identified family history, 5% of them will be because of a LRRK2 mutation. And then it's enriched further by certain subpopulations. Ashkenazi Jewish patients are really nearly 20%. There is responsible for 20%. LRRK2 is responsible for nearly 20% of Parkinson's disease. And if you're Ashkenazi Jews and with a family history of Parkinson's, then there is a 30% likelihood that you have the LRRK2 mutation. It is only higher in one other population, the North American Arabs with Parkinson's disease. They are 40% likely coming from a LRRK2 mutation. And so this is quite relevant. And LRRK2 animal models are also increasing our understanding of Parkinson's disease. The fascinating thing about LRRK2 is that not all of them have Lewy bodies. Some of them don't have Lewy bodies. And so it's really challenging our understanding of what is Parkinson's disease. Do we rely on the genetic mutation, or do we require Lewy bodies? LRRK2, the other thing about LRRK2, it's not an all or nothing. It's not like Huntington's disease. Once you have the LRRK2 gene mutation, it doesn't mean you're going to get Parkinson's disease. It means you have the gene mutation, but you may not have Parkinson's disease. The penetrance, the likelihood of you manifesting Parkinson's disease by age 70 is still 50% despite having the LRRK2 mutation. It increases further when you reach the age of 80. So the older you are, the penetrance increases. But it's not a guarantee that you're going to get it. I mentioned there are many susceptibility genes. And so they don't cause Parkinson's in itself, but they increase the risk of developing Parkinson's. One of the more intriguing ones that have been reported of late is this glucocerebrosidase mutation. So say that 10 times. It's tough. So GBA is the shortcut. This GBA mutation is quite fascinating to me. As you could see here, this is anything in this, beyond this line, is significant. So you could see that 9 out of 10 studies done looking at risk factors of GBA shows that GBA mutation increases the risk of developing Parkinson's disease. It started with just a simple observation that patients with Gaucher's disease, which is a liver lysosomal storage disorder, autosomal recessive, patients with that, they have more family relatives and themselves have Parkinson's disease than those what seemed like from the general population. So studies kind of led to this, and we then found out in general, meta-analysis, that having a GBA mutation increases someone's risk of developing Parkinson's disease by fivefold. And perhaps the more important implication of having a GBA mutation is not just the risk of developing Parkinson's disease, but once you have a GBA mutation, they have a higher risk of developing dementia or cognitive decline compared to Parkinson patients without the GBA mutation. So there is a prognostic or course implication for the GBA mutation. So is genetic testing justified? The answer to that, obviously, is it's actually more complicated. It's not a simple yes or no. I wish there was an easy button that I can press, but it isn't. So points for yes, justification of genetic testing is that, you know, it can confirm the diagnosis of Parkinson's disease. You could have potentially a patient with Parkinson features and a little bit of dystonia and other features, and then you notice that they have a Parkin mutation or a Park5 or Park14, Park19 mutation, then your diagnostic testing stops. The patient has Parkinson's disease. So it limits other testing. It tells you the risk of developing Parkinson's disease, like GBA. And some patients, they just really want to know. Knowledge is power, and I want to know if I have a risk or I have Parkinson's. You want to, obviously, by knowing whether you have an autosomal recessive or autosomal dominant or simply a susceptibility gene, you know the risk that you give to family members and you can answer their questions. It might assist in family planning, especially for early onset Parkinson patients. And now, at least as an example, the GBA mutation, it gives you a window to the possible prognosis. And as we develop better therapies, especially neuroprotective therapies, knowing that you're at risk puts you in front of the line when these neuroprotective therapies are being studied. So these, especially when you have a gene mutation-specific targeted therapy, when we have a alpha-synuclein gene mutation therapy, then obviously those with the alpha-synuclein gene mutation would be the first in line. So it just makes sense to know your gene test to get it. So these are the justifications for that. On the contrary, it is really often unhelpful clinically. You know what's Parkinson's disease. It looks like a cat, smells like a cat, it's likely a cat. You don't really need to have any more testing for this. The diagnosis is usually clear clinically. There is really minimal benefit except for that GBA mutation. They would follow a disease course. And even that is not an absolute rule. You always have exceptions, and all you do is you cause worry that I'm going to have dementia, and then they never get dementia because they have a GBA mutation. We still don't have any neuroprotective treatment to this day, so knowing the gene today doesn't really help it, at least at the present time. We don't have gene-specific therapy available. And most Parkinson patients, they develop it, even early onset will be at 40 or 50, they already have their kids. So they can't undo that, and so family planning usually is not an issue. And because even our most common gene mutation, which is LARC2, is only seen in 2%, really over 90% of our patients will have a gene negative test, and it's quite expensive as well. So there are pros and cons to genetic testing at this point. The most important thing is that you empower your patients to know these pros and cons, and then they fit, and then you basically decide together what is the best fit for that particular patient. You also have to, once you know that you have a gene or no gene, it's harder to lie in forms and stuff like that. So sometimes ignorance is bliss, although knowledge is power. So you have to weigh those things. So what about how our world around us affects the way we see, or the way how some people develop Parkinson's disease? So there are certain risk factors that have been consistently shown to more likely cause Parkinson's disease. So one is head trauma. Clearly, head trauma, especially those with loss of consciousness. Doesn't mean you're going to get Parkinson's disease, but it increases your likelihood. Certain pesticides, paraquat exposure, and rotenone exposure also increased risk for Parkinson's. On the flip side, there are certain things, true or not, that is associated with a lesser likelihood of developing Parkinson's disease. One of the more consistent and intriguing one is smoking. People who smoke are less likely to develop Parkinson's disease. Not a license to smoke, not a license to kill yourself, but it's there. Whether smoking actually reduces Parkinson's or that smokers really are capturing a subset of a specific kind of person that are less likely to develop Parkinson's is really unknown. Those who drink quite a bit of coffee, this is not one coffee per day, this is like a Starbucks pre-addiction level, they are less likely to develop Parkinson's, and they have even anti-tremor effects and stuff like that. A few other decreased risk factors for Parkinson's disease that really came from epidemiological studies. These are studies that just surveyed thousands of patients, hundreds of patients. Those with gout or even high uric acid, at least in a lot of our neuroprotective trials, really had the slowest disease progression of Parkinson's, or were less likely to have Parkinson's disease. In a 3,000 epidemiological study in the UK, patients who were on a calcium channel antagonist for hypertension were less likely to develop Parkinson's compared to those on any other antihypertensive. There have been some data that in high vitamin D and even high total cholesterol, believe it or not, are less likely to develop Parkinson's disease. Again, not a license to eat what you want and smoke and drink coffee and get a gout flare, but these are just things that have been reported. So the truth of the matter is that pure genetic Parkinson's disease is likely uncommon. As you know, even the most common disorder, genetic mutation, LRRK2, is really seen in only 2% of the population. Overall, less than 10% of Parkinson patients are because of a gene mutation. It is also less likely that you have Parkinson's pure environmental Parkinson's disease. If this was the case, then we would have observed clusters in parts of the world with a high incidence of Parkinson's. We don't really have that, clusters that we see. So the bigger likelihood is that it is a combination of genetic susceptibility with an environmental trigger. So a perfect example of this is this alpha-synuclein REP1 gene susceptibility variant. If you carry this gene, you have, less than twofold increased risk of Parkinson's disease. If you have a head injury, especially repeated and with loss of consciousness, then you have also a slight increased risk of developing Parkinson's disease. But if you have this gene variant with head trauma, then it increases your Parkinson risk tenfold. So this is an example of a perfect storm being the likely trigger for Parkinson's disease rather than pure genetic or pure environmental. So what about the way we think about Parkinson's disease? I mentioned that although Parkinson lack of dopamine is the hallmark of Parkinson's, we now know that there is a lot of moving parts to this equation, and that the balance of so many other neurotransmitters is really critical in our understanding of Parkinson's disease. But perhaps there's nothing more revolutionary in the way we think about Parkinson's than the one that Brock, a German pathologist, neuropathologist, described. So in medical school, when we were in school decades ago, unfortunately, so we were told that Parkinson's disease starts in the midbrain, in the substantia nigra, and that there are Lewy bodies in the the substantia nigra, and that's the start of Parkinson's. Well, Brock looked at this because of advancement in alpha-synuclein staining. He was able to look at these clusters of Lewy body and really tell us that it doesn't start in the substantia nigra, which is in the midbrain, which is here, but it actually starts in two areas, in the lower brain stem and in the olfactory tubercle. So outside, even before the substantia nigra, and then it doesn't stop there. It obviously progresses all the way to the cerebral cortex. And this is a big advancement in our understanding, pathological understanding of Parkinson's disease, because it tells us that Parkinson's disease actually starts in the peripheral nervous system, outside the brain even, and then invades the lower brainstem, upper brainstem, and then the brain itself. And this, starting in the peripheral nervous system and the olfactory tubercle, really cements this understanding, this notion of a premotor or prodromal state of Parkinson's disease. So there is that premotor state, which is rather critical if we're going to cure Parkinson's disease or develop neuroprotective therapies in Parkinson's. So when the olfactory bulb is involved first, a corresponding correlating non-motor symptom would be lack of sense of smell, or what we call hyposmia. And then in the lower brain stem, in the medulla, you have the dorsal nucleus of the vagus and the sympathetic ganglia, and involvement of that will result in constipation and some urinary dysfunction. And as you go up the chain, you affect the pons, the locus coeruleus, and this could be responsible for a lot of patients being depressed even years before having Parkinson's, and the high chance of depression in Parkinson's disease. And then you go up higher, then you can have what we call REM behavior disorder, when they act out their dreams and stuff. So, and this is quite important, because we now have established premotor, this is before the shaking starts in Parkinson's disease, this loss of sense of smell, REM behavior disorder when they act out their dreams, constipation, depression, and anxiety. And this is critical because they can start even 1 to 2 decades before patients actually start shaking and shuffling in their gait. If you look at this, if you look at those who can't smell as well, these are patients with hyposmia. They score in the less than 11th percentile, in the 10th percentile or less. They're twice as likely to be depressed and constipated, and also have REM behaviors, 2.5 times more likely to have REM behavior disorder. And if you have more than one of them, they're almost 3 times as likely to have loss of sense of smell as well. So they're quite interconnected. This REM sleep behavior disorder is not specific to Parkinson's disease. They can also have multiple system atrophy or dementia with Lewy bodies, but it really increases the risk. In 5 years, if someone has RBD, they have a 20 to 40% chance of developing Parkinson's, and in 10 years, it's 40 to 65%. And so this long time, this is the time that they actually, this is before the motor symptoms, and this is after the motor symptoms. And so this long decade or too long period, the prodromal or preclinical or premotor phase, is really important to us because we can intervene at that point. And you see, after they develop the motor symptoms, the diagnosis really follows shortly. But the trajectory is really a steep downhill curve from here. So this is the best chance of getting it. And DAT scans, for example, can see that even before we see the motor symptoms of Parkinson's disease. The problem is that obviously we can't get DAT scans on all patients before they develop Parkinson's, but we have a hint that we can do. So the notion that there is this long premotor phase and the notion that we can measure it, say with a DAT scan as an example, and the notion that we can identify them a little bit by looking at patients who are constipated, who are depressed, who have REM behavior disorder, who have certain genetic susceptibility is very intriguing, and it really gives us a chance to practically study compounds for their neuroprotective effect. So this is one example of a statistical calculation to make it a bit more realistic to you guys. So let's say we have a drug that, say, improves Parkinson's, is likely to reduce the incidence of Parkinson's disease or prevent Parkinson's disease by 50%. So if you take this pill early on, you are less likely to develop Parkinson's by 50%. So that's a powerful drug, right? I mean, who wouldn't take that? 50% less likelihood of developing Parkinson's. So how many patients do we need to find 80% power to determine whether indeed this is correct? If we study the general population, because of the low incidence of developing Parkinson's disease, we will need close to 5,000 patients in each arm, the study drug and the placebo drug, because only 47 out of nearly 5,000 will develop Parkinson's. So you need that much to see if your drug will prevent Parkinson's disease onset by 50%. However, if you enrich that population and say, we only get patients without Parkinson's yet, but with REM behavior disorder, you only need over 200 patients per arm, because the likelihood of a patient with REM behavior disorder of developing Parkinson's is higher. And if you say, well, let's get patients with REM behavior disorder and can't smell very well, and if you have that, you only really need a little over 100 patients per arm. And that is a very doable study. So databases that account for REM behavior disorder, lack of sense of smell, really will come in very handy when we have genes or therapies that might prevent Parkinson's disease, because you increase the yield of finding out whether that drug really helps in preventing Parkinson's disease or not. So biomarkers, I think I've extended my time, but there are many, many biomarkers that we're looking at. Lack of sense of smell, and I think the clinical ones I already mentioned. We're looking at various sources, urine, blood, CSF, even salivary gland and stuff, to see, look at alpha-synuclein and other things that, mainly alpha-synuclein and other markers that we can see. And then also we have the imaging, PET scans, SPECT scans, and even ultrasound that might be potential markers. So knowing that the peripheral nervous system is involved in Parkinson's disease really has allowed us to look into markers outside the nervous system. One of the most promising one is this cardiac MIBG scintigraphy. It's really more common in Japan than in America, but this is quite specific to Parkinson's, and because of, it causes constipation and affects other parts. There is now even some suggestions that we could even see it in the colon biopsy and skin biopsy. So this is an example of MIBG scintigraphy. So MIBG scintigraphy, it's a nuclear scan that looks at the integrity of the postganglionic sympathetic fibers. And if it's normal, you could see the increased uptake in the heart region, it's dark, compared to the mediastinal region, which is lighter. That's a normal ratio of a mediastinal heart uptake. And in Parkinson's disease, you could see, because there is a postganglionic sympathetic dysfunction, it's almost as light as the mediastinal. The heart mediastinal ratio is not quite normal. So this is actually 80% specific to Parkinson's disease. So when you see that, it most likely, indicates Parkinson's disease. Skin biopsy, fascinating because of our technology in alpha-synuclein staining. You could see Parkinson patients with alpha-synuclein staining in the skin and not in the control patients. Colon, because through the benefits of flex sigmoidoscopy, a colonic biopsy in the sigmoid portion of the colon shows these are early untreated, 11 early untreated Parkinson patients with alpha-synuclein staining compared to 23 patients with irritable bowel syndrome and healthy controls. The same investigators, Dr. Shannon and her group at Rush, also showed that you could see this synuclein staining even before, 2 to 5 years before they actually develop Parkinson's disease. So it's quite promising. Ultrasound I like a lot because it's quite commercially available, and you could see the echogenicity differences in the ultrasound of patients with Parkinson's disease compared to controls. Now, this is a very tight window you're looking at, so it requires a lot of technical expertise and still some validation required in it. What's commercially available is a DAT scan right now, and any neurodegenerative Parkinsonism will have decreased uptake in that DAT scan, whereas any non-neurodegenerative Parkinsonism will have a normal kind of cashew-shaped, comma-shaped uptake because of a really intact pre-dopaminergic systems. So in the DAT scan world, you could divide them into the east and the west, where anything in that line, really, if you have a patient with essential tremor, psychogenic, drug-induced Parkinsonism, should have a normal DAT scan, and anything on this side should have an abnormal DAT scan. And so if your intention for developing, getting the DAT scan is to distinguish between Parkinson's disease and PSP, that's not the right test. It's not going to give you the answer. But if your question is, does this patient have Parkinson's or essential tremor, or is it Parkinson's or drug-induced, the DAT scan would be very helpful for you. FDG PET is the one that can differentiate, if done correctly and interpreted correctly, the different kinds of Parkinson and Parkinson plus syndromes. Okay, and then you have also alpha-synuclein imaging and tau imaging that will be, I think, very relevant in the next few years. As for the diagnosis, it's still very clinical. It's still very clinical, but we're now slowly recognizing that there are certain non-clinical aspects that really assist us in our supportive diagnosis of Parkinson's disease because we recognize that if we are just clinical per se, even for those with well-established Parkinson's, 5 years or more of Parkinson's, as good as we think we are wrong, at least 12% of the time. And this is compared to autopsy. And if a Parkinson patient, the Parkinson's is less than 5 years, we are wrong nearly 50% of the time. We are wrong nearly 50% of the time. And the mistakes come from other diagnoses. They actually have PSP, Alzheimer's even, multiple system atrophy, vascular dementia, et cetera, et cetera. So we need supportive features of Parkinson's. And the MDS task force was commissioned to look at, what is a likely or probable Parkinson diagnosis. And they stuck, for the most part, with clinical criteria. Clear dopaminergic response is indicative of Parkinson's disease. When they develop levodopa-induced dyskinesias, likely because of Parkinson's disease. When they have resting tremor, that makes it a lot easier. But at least now they have recognized that when you have a patient with olfactory loss, with hyposmia, that is a good supportive feature of Parkinson's disease. And if you have MIBG scintigraphy, that doesn't show that heart uptake, then that is a strong supportive feature of Parkinson's disease. So baby steps. We are now including other features that we, and putting them as supportive for the supportive criteria for Parkinson's disease. So I think that's all I have for today. I'd like to, at the clinic, we say that it takes a village to provide world-class care. I'm the one talking all the time and getting the glory, but I have a huge supporting cast, part of our team way back home, and and I owe everything to them, and I'm so happy and so fortunate to be working with a great group of folks. So thank you very much for. Can't help but we're here, so someone has to win and someone has to lose, and maybe next year. So thank you very much for your indulgence. Sorry for
No, so we are running late. We started a little bit late, but I don't know if we can take one or two questions if anyone has any. I'm sorry.
Yes. It is, yes. That's correct. Well, it's just a risk factor. It's not a certainty that you're going to develop it. That's the beauty and also the ambiguity of epidemiological studies and risk factors, because it doesn't mean you could have a 20% risk or a 50% risk of developing Parkinson's disease, but you may not also have it. If you have a 20% risk of developing Parkinson's, that means you have an 80% risk of not developing Parkinson's. So you could beat the odds and not get it. So that's the reason. It's just a risk factor. Yes, sir. Yeah, yes, there is. I just don't know the pattern.
Actually, can you repeat the question, Hubert?
So the question is that, is there, and maybe you know the answer to this more than I can, or I know. So the question is there a smell pattern that is more suggestive of Parkinson's disease than not? I think the answer to that is correct. And the reason for this is we test the lack of sense of smell through a test called UPSIT, University of Pennsylvania Smell Identification Test, UPSIT. And in that test, we scratch certain different scents, and they sniff it, and then they try to identify it. And then there is an emerging pattern. There's like 20 scents that they have to identify, that they are less likely to identify certain scents more than others. And I just don't know which particular scent to this. Do you know?
No, actually, I think there are studies where it shows certain scents are more specific, are more sensitive in Parkinson's disease, but it's actually highly variable in most of these studies. So.
When
Yes.
somebody has a routine sleep study, would you be able to pick up 3 grams of disease at that point?
It's possible. It depends on why you are getting the sleep study. If you're getting the sleep study for obstructive sleep apnea, then you may or may not get it. And it also depends on what the sleep center is. And if you do a comprehensive sleep, study, and you have EMG leads on the limbs as well as an EEG while the patient sleeps, you should be able to pick it up. But if you're looking at it from a different standpoint, especially if you have a pulmonary-based sleep center, you may or may not miss it. It depends on the bias of the clinician.
All right, this will be the last question, and then we have to move on.
Associated decrease in taste along with the decrease in smell.
Typically, yes. Yeah.
Some people may notice that before they notice
Well, some people may, and also it's interesting to us that not all patients know that they have a decreased sense of smell. And because now we routinely ask this question to all our patients, how's your sense of smell? And then the patient would say, oh, I'm good, and then the wife would just slap him like, you can't smell anything. And so you have that. So there's, okay.
All right. Well, thank you, Dr. Fernandez.